So another thing when we talk about shoulder surgery and what we do and kind of this combination of things, the combination of we're having a rotator cuff repair, we're going to have a subacromial decompression, we're going to have a distal clavicle excision, we're going to have a biceps tenotomy or tendonidesis. So those are all kind of conjunction. So they're all things that we can do together if we need to. We don't always do everything together. We often do many of them together. So one of the things we talk about when we're looking at the shoulder, we're looking at the shoulder joint. So sometimes we do some things in the joint itself. We look at the rotator cuff. So sometimes we fix the rotator cuff or maybe just debride the rotator cuff. Sometimes we take a little bit off the acromion called a subacromial decompression. And then sometimes we do something with the joint here, the distal clavicle in the acromion, so the AC joint. We don't always do this because sometimes we have some arthritis at this joint. And we see that a lot of times in people with rotator cuff tears. But this arthritis doesn't hurt, which means this joint doesn't move very much in general, even when you're young. And as we get older, it moves less. And oftentimes we'll have some arthritis, and it'll fuse the joint, which means the joint won't move at all. And if the joint doesn't move, then it doesn't hurt. So we may get an MRI, and we may get an MRI that says AC joint arthritis, but it may not be have any symptoms. If it doesn't have any symptoms, then we're not going to address it. And that's why it's really important whenever you have an MRI review with your physician that you understand each little step in that MRI and why you might do something about it and why you might not do something about it. But if it does hurt and we're having pain up on the top of the shoulder, we'll do what's called a distal clavicle excision or a DCE. And what that entails is us going in there in this arthritic joint, depending on the surgeon will take a little bit off this, sometimes 5 millimeters, sometimes 7 millimeters. It just depends on what the surgeon feels most comfortable with. And that taking this away would give us some relief of that arthritic pain. Now, the thing is, when you do a distal clavicle excision, it hurts for the longest. It hurts actually longer than rotator cuff repairs. And so we want to make sure that we're really confident that we're having pain here before we do that surgery. And lastly, we talk about one more thing, biceps. So the biceps tendon comes up in between the rotator cuff, subscapularis here, supraspinatus here, comes up and comes around and attaches to the top of the socket. So sometimes we have some damage of where the biceps attaches to the socket. And when we have that damage, we have to figure out what to do with it. And there are a few things to do with it. And some of it has to do with the expertise of the surgeon. Some of it has to do with the age of the patient. But the short answer is if you are 40 plus years old and you have a rotator cuff tear and you have a problem with your biceps, oftentimes we will release the biceps right here. When you release the biceps kind of slides back and gets stuck in this spot here. There's a little tunnel that it goes through and it gets stuck in the tunnel. And so oftentimes that's all we might do. We may just let it stay there, get stuck in the tunnel, and heal there. If we do that, sometimes we may have some additional biceps pain because the biceps is not at the right tension, right? We change the tension. It used to be attached here and now it's attached here, so a little bit less tension. So sometimes we get biceps tendon cramping, or sometimes you might be able to notice it in the muscle belly. So there's a debate in orthopedics actually what to do with this biceps. If you release it or if you reattach it, there's not a really clear-cut winner. So a lot has to do with maybe the person that we're actually doing it on. If I'm going to do a younger manual labor type person, I'm worried about biceps cramping, then I'm probably going to do what's called a biceps tendonidesis, which means I'm going to reattach it. I'm not just going to let it slide here. Depending on the person, I'm going to really either reattach it here, so tension it, put an anchor there and reattach it here, or maybe a little bit lower. That has to do with a few technical reasons for how we're fixing the rotator cuff. But so with someone younger or more active, we may re-tension it, reattach it. And for someone older or less active, we may just release it. Again, the studies show that there's not a really clear-cut winner, and that's why some people might have a biceps tendonidesis, which means we actually tenodise, which means reattach it, versus a biceps tenotomy, which means we just cut it and it kind of falls back in here and attaches back there. So biceps tendonidesis, biceps tenotomy, in addition to all the other things that we can do in the shoulder. It all has to do with what's really wrong in the shoulder, And again, that's where you got to really talk with your doctor about, well, what is going on, what's important, what hurts me, what doesn't hurt me, so we can make sure we're doing the right thing for you.